Thank you, Alister. Thank you for that beautiful welcome. Is my mic working? Yes? I would like to acknowledge the traditional owners and pay my respects to your elders past and present. Thank you for having me here on your homelands. It's not proper if I don't introduce myself in my own language. Bujuani, Nishpigage, Jabikwe, Karen Diver, Nindigenous, Makwa Nindodem, Nagachi Wenang Nindujaba. My name is Morning Sky Woman in my language. My English name is Karen Diver. I am of the Bear Clan, of the original people from the head of the Big Waters, in other words, Lake Superior. That is my formal greeting to you, so thank you for having me again. I am also, would be considered an elder in my community. I'm not real comfortable with that because I'm not that old. And the reason, well, don't look at me like that, young people. I would like to consider myself firmly middle-aged, but I've moved into auntie territory, and why is that? Because the average age of death for an American Indian in the late 60s was 56 years old. So I'm 54 years old. I would be looking at most certainly the end of the last decade of my life, if not a couple years. And so a lot of our programming, health programming, nutrition programming, our loss of access to traditional culture and traditional foods, a lot of those things contributed to a very high morbidity or mortality rate. And this was really key to tribes looking at asserting themselves over their health systems, because our elders are an enormous part of our preservation of culture, language, spirituality, identity as Indigenous people. And so tribes prioritizing health systems was exactly the reason why it was because of that rate. So my dad is now 80. My mother is 77. What a tremendous gift in the intervening 50 years to be able to have those kinds of impacts on health outcomes and Native communities. So I might be an elder, but I'm not that elder yet. So I wanted to talk a little bit. I have, through my research, seen the wonderful work that's happening here in terms of investing in Indigenous healthcare and Aboriginal healthcare. In some ways, I think it's really remarkable and a model. But for the purposes of comparing and contrasting what might be either proactive steps that can be taken or models or something that we can learn from you, these conversations across Aboriginal and Indigenous communities are really very, very important. Okay, so we wanted to talk a little bit about what are the US models of Indigenous health delivery and how did they kind of develop. Back when treaty making was happening, and while that's happening now here, it was happening in the early 1800s in the United States as the United States was continuing to form. And they signed treaties with Indigenous people basically to put the Indian problem to bed. They didn't want warfare, they wanted it safe for settler colonialists, and treaty making was meant to resolve some of those conflicts. And they created final homelands, what we call reservations, and tribes gave up vast swaths of territory in order to have these treaties be signed. They were under duress. It was either that or else they were going to send them the army. But there was some forethought on the part of Aboriginal and Indigenous leaders back then about what was the price that needed to be paid for the loss of homelands. One was the continual right to access those broader areas outside of the reservation for traditional hunting, fishing, and gathering. And the price that needed to be paid by the United States in addition to that was that the needs of US Indigenous tribal peoples would be taken care of in perpetuity for their general well-being. And the general well-being was considered health, education, housing, those types of things that maintain a sense of livelihood. But huge swaths of territory. For my tribe, there was 5 different treaties stretching all the way through northern Michigan, northern Wisconsin, northern Minnesota, all the way up to Canada. That's a lot of real estate to be left with 100,000 acres of remaining homelands and the right to hunt, fish, and gather. So those general health and welfare provisions were actually thought of by tribal leadership at the time. They were conquered folks, and like I said, under duress, but they knew that the health and well-being on an ongoing basis was the price that should be paid by the US government. Now, we all know that that didn't end kind of hostilities, whether it was from the United States government to indigenous people as tribes, political entities, or the effects that racism have on service delivery and how you implement what health and service delivery looks like in these home communities. And so people kind of get confused about why tribes in the United States have this special relationship with the United States. It's treaties. Only governments under international law can make treaties with other governments, that sovereign relationship. And even that has not been followed by the US government, but that's a political status, not a racial status, right? So that's how our special relationship with the US government is really formed, is recognizing that that's between political entities. Are we a race of people that has a special cultural traditions and spiritual traditions and long history on our continent? Of course, but the relationship is based on the political status. Up and down through the years, outright hostility and actual genocide probably stopped by the early 1900s, but the relationship of tribes being able to govern themselves has also fluctuated along with its relationship with the United States. The constitutional relationship, tribes are actually mentioned in the US Constitution. It's the only racial or ethnic group or other form of government besides states that are recognized in the US Constitution. So many of us who are tribal advocates when we're in Washington would carry that Constitution out with us and whip it out every now and then to remind folks that it's a political status. Things didn't really change for tribes, though, as an occupied homelands by the US government and states until the 1970s, and that was really an outgrowth of the US civil rights movement. Much like African Americans in the US really had to kind of get loud and disruptive to show attention to a lot of the inequities that are due to their race, an unintended byproduct was really Native American people who also raised their voice up in protest and said, inequities are happening with lots of racial and ethnic groups in the United States, and then you have these tribes that also have this governmental status. And so out of that civil rights movement, you saw some really landmark legislation geared towards tribes. One was self-determination, that tribes could control their own service delivery systems that up until that point were only run by the federal government in reservation homelands. Run badly. It was a hub and a spoke system into regions from the federal government down to regions. But it also was around education. It was around building up tribal governments. It was about schooling, all kinds of the breadth of what you would see under traditional government in the 70s started getting devolved from the federal government to tribes. That self-determination was really supposed to be funded at the level it should have been to replace the federal government. So it said, you know, if it costs the government this much to provide services on my homeland, Fond du Lac, then that's what the tribe should get to run it instead of the federal government. That never worked. And it never happened, and to this day still hasn't happened. But tribes are kind of entrepreneurial, right? And they're happy in running their own service delivery for their own people. So this tribal control of service delivery really allowed tribes, it was almost like a block grant format. So what did you want to take over? And there's two things that Fond du Lac decided to do first in the 1970s. And I always find it ironic because you can tell what people value based on what they invest in, right? And the first two things my tribe took over was they hired a nutritionist and a fish biologist. Isn't that an interesting combination, right? They were worried about that morbidity and mortality, right? So health. You can't start with chronic conditions, you have to start with wellness, right? So the nutritionist and the fish biologist was around traditional hunting, fishing, and gathering, but it was also around food security, because commercial activities from majority populations in industry was starting to degrade the resource. So in many ways, that was about health as well. They saw a diminishment of their ability to catch fish in the inland waters and riverways. Talking about that civil rights movement at the same time, Indian Child Welfare Act. I know that the indigenous people here also suffered from residential schools and things like that. We also had that in the US. This was an enactment of some laws that really prioritized tribal placement and preservation of culture and community, and tried to stop the stem of indigenous children being removed from the home and helping to create systems within tribes to help with that. That's only going mediocre, that also, although it's not residential school, now it's foster care. So that's something we're still working on, and other disparity issues. Tribal governments were really starting from scratch at the time, and those were very Western-formed governments. The governance model was imposed by the federal government, and frankly, it's really not ever gone really well since the early 1900s. It was not an indigenous-focused leadership. With over 570 tribes, every tribe had a governance model that was based on their own traditions. My tribe had a hereditary chieftainship. Some were matrilineal. Some were theocracies. They were all different, and they were formed for centuries within their home communities. And now all of a sudden you've got popular elections and supposed democracies like the United States is. This is not a lecture about how that's going. Can we just, but of course I don't have opinions about that. That president I work for was Obama, by the way. So any of you giving me the stink eye, knock it off. But tribes needed to make it their own because that's what they had, and that's what the federal government was working. So they had to indigenize foreign systems in a way, because if they didn't, it was going to be really foreign imposed, and you were going to have a legitimate leader under your traditional ways and an illegitimate leader, and it was further fracturing the communities. So owning our own governance is still an ongoing work today, in terms of how do we become modern indigenous tribes with governance systems that are reflective of our traditions and values. It doesn't mean that they have to be the way they were 300 years ago, but it does mean it needs to feel legitimate in the eyes of our community, and so it's going to need some tweaking. So we had this whole system of delivery that started being devolved down to tribes, but without any work whatsoever. So once they said, okay, well, we're not going to do your health services anymore, you're going to self-govern it, they cut you off. Like, there was no training programs, there was no manual. They literally left you on your own. And given that status of they were supposed to take care of our general welfare, you would have thought that there would have been a better transition strategy, right? And these communities in the 70s didn't have high levels of social capital at the time. So a lot of the people that tribes were bringing in were not indigenous to our own communities. But one of the pieces of legislation was the Indian Education and Self-Determination Act, which first started putting money into tribal scholarships and tribal education, and started the beginning of developing tribal colleges. So that was at least a long-term strategy of building that social capital within our own communities. Am I talking too fast for all of you, or am I doing okay? All right. I've had a lot of coffee since yesterday. All right. So what does that mean, kind of? That was the history and the framing for kind of what we got left with out of this craziness out of Washington and federal control down to state control. Down to tribal control. Has it made a difference? In some ways, yes, and in some ways, no, because we don't have complete systems available in tribal communities. We don't necessarily have everything from hospitals and emergency rooms and, dialysis centers and all of that. Some of them are small clinics. They're all different based on tribal capacity and funding, and their location, their tribal size, the amount of citizens that are part of their nation. But regardless, what we're still finding is healthcare delivery outside of tribal communities still doesn't feel safe to Indigenous people. And this is a fairly recent study by Robert Wood Johnson and Harvard School of Public Health that says that 23% of Native Americans don't feel like they're getting adequate relationship-based care based on their racial status and or their political status within mainstream medical institutions. The problem is then they're avoiding seeking care. And that's problematic with the high number and the disparities that exist around many chronic conditions in our community, in particular diabetes and cardiac, but also high rates of cancer. Some of these are linked to kind of environmental racism issues where the government allowed them to do uranium mining, other types of mining that impacted waterways, industrial activities. For the Alaska tribes are about half of the United States tribes. Up there, it's actually military contaminants up there because of its strategic location during the Cold War era. So all of those reasons is people are not seeking care, which turns preventable and manageable conditions into death sentences. Okay, so I talked a bit about what is the legal basis, and I talked about the Constitution. Here's some other ones. The Indian sanitation facilities, that sounds real sexy, right? These are rural homelands in much of tribal communities. And how do you take care of your community, that health part of it, and wellness if you don't have septic systems to manage wastewater or you don't have potable water? So sanitation is a part of what allows tribes to build housing communities and to increase the wellness in their own communities. I talked about that Indian Self-Determination Act. The Indian Healthcare Improvement Act was the funding stream that came from the feds to the tribes to do their own self-governance. That was an every 10-year funding appropriation, and so every 10 years it would expire. They would go on a continuing resolution. Tribes would get all scared, wondering what was going to happen, and then eventually they would pass it. With the passage of the Affordable Care Act, otherwise known as Obamacare, there was a permanent reauthorization, not every 10 years, of the Indian Healthcare Improvement Act. So that was a huge sigh of relief that they weren't going to have to spend a lot of time, resources, lobbyists, frustration, anxiety around how their health care was going to be funded. The Indian Alcohol and Substance Abuse Prevention and Treatment Act recognized that from a behavioral health issue, Native people were disproportionately impacted by substance abuse disorders. And it started housing it within the Substance Abuse Center, within the Centers for Disease Control and the Healthcare Department. Now, why are Native people overrepresented with substance abuse? Self-medication. There's a lot of trauma and generational trauma, and drugs and alcohol are a great way to self-medicate. We have some stigma within our community with talking around mental health issues and talking about the root causes of all of that trauma. We can talk about being a user, but we're not going to necessarily talk about physical abuse, sex abuse, racism, and all of those other things that contributes to ongoing trauma, not only from our ancestors and our elders, but how that manifests itself today with current trauma as well. So that is a huge part of kind of starting the healing and creating a place where people can have their trauma in a safe place and find more appropriate ways of dealing with it. And then we talked about that Indian Child Welfare Act. You can see how it's funded at about 38% of defined need. Now you're saying, man, that's terrible. Up under President Obama, it got up to 49%. which was something that was really proud. But it also gave some mechanisms to fund it alternatively and not just through the Indian Health Service funding directly to tribes. That opened up state Medicaid programs for tribes to bill. So it had an alternative financing mechanism, which is great, right? Because if you look at the spending per capita, we're paying more for US prisoners than we are for our indigenous people's health. So it says up there, referrals are limited by funding. So if you go to a clinic that that's either run by a tribe or run by the Indian Health Service, the federal entity, and still federally run, anything they have to refer you out of house for is paid by a fund that's allocated per clinic. Some of those clinics run out of that money in January. That would be ambulance services. That would be specialty care. Let's say I'm not happy with the way your heart sounds, Alister, and I want to send you to a cardiologist for some tests. In February, we can't pay for it because we ran out of the money in some cases in January. So this is a challenge for US tribes, is to figure out how to diversify and otherwise get really good at having as many comprehensive services under the roof as possible in their tribally run clinics, and or if it's a government run clinic, you have to figure out a way to get health insurance and not rely just on Indian Health Service. So let's look at the numbers. I'm not going to read all of these to you, partly because you can see them. But you can look at the disparities. Obviously, we talked about substance abuse, so you can see the disproportion in alcohol related, and that also would be for chronic liver disease and cirrhosis. But actually all of them, assault and homicide. People assume that that is race-on-race crime, and it really gives majority populations kind of a free pass for their own racism and how it manifests themselves. And the fact of the matter is, it is not race-on-race crime. In fact, it is over 90% other races, which goes to racism, right? And the thoughts of that indigenous people are disposable. At particular risk are indigenous women and girls. We have a problem in the United States, Canada, and Mexico around missing and murdered indigenous women because of the jurisdictions on tribal homelands, where you have federal jurisdictions within states, and we are a states' rights country. Missing and murdered indigenous women. There's jurisdictional issues, and they just really don't even have good data. They need to federalize the data and compel states to start to track. When a lot of the violence against indigenous women's advocates have asked states what their numbers are, they can't even name them. And so some grad student actually started doing research and started a missing and murdered indigenous women's site just to start collecting the data, because other jurisdictions obviously don't care enough that this number is so high and is overrepresented with indigenous women and girls. So that's something we really got to work on. Some of the things that contribute to this, obviously, are what we consider the dehumanization of indigenous women. The whole Pocahontas phenomenon, right? Where we become fetishized and sexualized. Well, the more you make indigenous women not human, the easier it is for them to become victims. You all heard of Standing Rock, right? A friend of mine was talking that during the height of all of that, she wasn't involved in any of the protests, had family, she didn't have time for it, working woman, had kids and a husband and obligations, and she's walking through Bismarck with her 6-year-old girl, Bismarck, North Dakota. It's pretty much in the middle of nowhere, but it's near the Bakken oil fields where they're pumping the oil from to south, and what created the Standing Rock. And she's standing at a light with her 6-year-old girl, and a guy in a pickup goes by and yells at her, "How much for your girl?" And the scary part is, she knows it could be her girl, the next statistic, right? Because Violence against Indigenous women and girls is a colonizer strategy, because there is nothing that people with power can do more than subjugate women and girls in order to kill the will of a people. This number is no surprise to me. It's a tool of war and control. Anyway, you've read it. The health outcomes are obviously tied a lot to poverty as well. Poverty, access to traditional foods, etc. So the Indian Health Service is that direct care run by the federal government, 170 facilities in total between Indian Health Service and tribally managed. Tribally operated ones have the exercise, I was talking about that self-determination, but then there's also a nonprofit version. Half of Native people in the US do not live in reservation communities, they live in urban centers. There was actually a huge push from the feds to try to disassociate Native people with their traditional homelands and try to get them to move into major urban areas. But we're a resilient people. We know we're still Indigenous. We're just kind of urban at the same time. So they started these urban Indigenous health programs as well. So you can see how it breaks down. Right now, the tribal ones are outpacing the Indian Health Service, although the Indian Health Service still runs more hospitals. A lot of that is just around the cost it takes for facilities and equipment. For hospitals, it's much easier to run clinics. You know, you don't have to worry about surgical services, all of that other stuff that's pretty expensive. The Alaskan villages in particular, some of these are small and remote. These are fly-in communities that might only have 30, 40 people. And they might run their clinic with one person part-time, but then the rest is done by telehealth. And then they figure out how to get them into bigger cities to provide anything that can't be done. Alaska in particular, in terms of remote communities, is really doing some really model work on how to build capacity. I mean, if you get a nursing degree, what's your incentive to go back to a village of 40 people? How are you going to earn a living to pay back your student loan debt, et cetera? So they need to figure out different models of service delivery in order to make that happen. All right. So Indian Health Service only does direct primary care. They have those hospitals and some limited dental services. This is a problem, limited dental. I mean, do you know how many health problems can be identified by having a good dentist? You could figure out heart disease, diabetes, all kinds of stuff, right? And oral health care is really a part of overall health care, and they don't fund it. Well, what's the good of funding their heart disease later if you can't take care of something along a preventative care like dental? If anything is considered not life-threatening or not a health threat, it won't be covered under Indian Health Service funding. Severe acne. You try telling an 18-year-old's mental health that acne isn't a problem. Or the cosmetic need for braces, right? Those are indicators over time of your economic and social status. If you are a nice middle-income kid, you're able to get your teeth taken care of. So those are things that other people use to judge you, right? Not to mention your own self-esteem and self-worth. And then we have these pockets where things just aren't getting as better as quick. Although that average age of death is now 76 for a Native person in the US, Montana is still not great. Part of it is how rural it is. Part of it is a lot of it's still run by the Indian Health Service, which isn't run very well. They actually had their accreditation yanked back for 2 of their hospitals in South Dakota, and the tribes are trying to figure out how to take it back. So the federal government itself that ran this program had their accreditation taken away for their hospitals because they were run so poorly. Apparently a Native woman gave birth on like their waiting room floor because she wasn't seen in time in a hospital. You know, so these are just abhorrent, but there's pockets of this still across the US, and Montana is one of them. But we do see some models of success, and they're almost always driven by tribes. So this is one of the things that we've been learning from internal to the US is we know the answers on how best to serve our communities. We see these models being developed and replicated where tribes are just taking a chance. And you know what? Sometimes they tried something that didn't work. Okay, that's worth learning too. But when they do find something that works, then we have something that can be replicated across Indian country. Because a failure it's just money. Not trying is that average age of death staying what it is. I will always waste money in trying to have a better health outcome. That's where Indigenous people are motivated by different things. Whether it's in healthcare or any other system, majority systems are generally motivated by profitability, cost centers and returns on investments and, all of those other fancy words that always come down to money. There is no price that can be put on my mom and dad, right? So we're not motivated by the same things. It could cost more and still be worth it. I would rather still be poor as a people and have great health outcomes for our folks. So the balance, and so that's one of the reasons why our healthcare system is so messed up in the US, right, is because it's corporate, right? Let's talk about Apache tradition. That whole holistic look at health that was very much informed by their cultural traditions. The best models are informed by who we are as Indigenous folks, and the Apache took that. They were the first ones to get international accreditation. They figured out a way to get their own people educated and build up that social capital within their community because they knew that one of the best effects they could have on health outcomes is about building that trust and changing that statistic that I put up in the beginning about discrimination in healthcare delivery. When you see your cousin's son and he's the one taking care of you, that's a whole healthcare delivery model difference in terms of the relationship you have with your provider. Now you're talking to family. You know they're going to take good care of you because they're motivated by something different, right? And they also know who you are, they know who your parents are, they know who your grandparents are, they know who your kids are, your kids play soccer together. That's different. Now you're taking care of people in your own community and your own family, right? But also their behavioral health programs, once again, you would know this here. We know this in the US for our Indigenous folks. Where our racial identity and our cultural history has been used as a negative against us, and people have internalized that, when we take control of that narrative and it becomes our source of strength and our source of pride, it's also a source of our resiliency and healing. So the more you can have these programs that are grounded in your own ways, and you change them into something that you know is continuing the path of your elders, taking their pain and turning it into your own resiliency and strength, that's what's going to heal our people. And the Apache are finding that out.
The healthcare we got in the past was substandard.
It was just whatever came along. I believe they did the best they could, but it's just whenever someone came to Metlakatla, we were checked. If they didn't come, we weren't checked.
At first, a lot of people were not sure whether they could actually do it.
There's so many things when we first started that people say it couldn't be done. We don't have the money, we don't have the expertise.
Taking control was key in how well we take care of our health.
We went from having second-class health care to we got the best health care in town. And we did it because we're running it.
Having our own people managing our own health care has really helped to empower us to be able to talk more about the traditional practices that help us prevent chronic disease or keep us healthy.
Tribal leadership is making all the difference in how we're improving care.
We really are cutting-edge healthcare. We provide healthcare that is holistic and healthcare that is innovative and creative.
Being able to manage our own healthcare within the Alaska Tribal Health System has really allowed us to be creative with our prevention activities. This year, ANTHC's Wellness and Prevention Department hosted a paddle making workshop. We celebrated our 10-year anniversary of being tobacco-free as a campus, and we hosted 3 regional Alaska Plants as Food and Medicine symposiums. We realized...
Okay, I'm going to stop there. It's longer, but you get the point of reconnecting with traditional foods, connecting kids to culture in terms of building their own resiliency and protective factors against those things that are harming us. Then you get into the technical part of actual healthcare service delivery. They started a training program for dental therapists. They had to take on the American Dental Association, who said, no, you need to have dentists, real dentists, and people that we licensed that are dental hygienists. And they said, we're a tribe, we're gonna license them ourselves. We don't need you for that. We're gonna exercise our sovereignty, and we're gonna do dental therapists who can do basic cleaning. They can look out for those chronic conditions that are indicative by your oral health, and they will be able to tell you, you need to go in. That next step isn't for me, but you need to go see this person. So it's an intermediary step that was much more affordable and was short-term training, and they could use their own people to get trained. And it worked so well, they started doing it with healthcare providers where they're training young people to go in and handle the stuff that's easy but could become hard. Is it the flu or is it a cold? Let's hop on to the telemedicine. And they could be that, it's kind of like a first responder for health. They're not gonna take care of anything, but they can do the triage. Even small things that the Alaska Native people did with this is they have this big medical center. How do you come from a village with 40 people? You gotta fly out, it's expensive. And Native people do not get sick with something bad and not bring their whole family with them. That is just not how it works. I mean, you've got everybody there, right? They understand that, how do you get those other folks from the village when someone gets sick and they're scared? They have a gift shop there where people can bring traditional goods there. They don't mark them up. They buy them outright. It's not consignment. It helps give them money in their pocket. And the tribe started a medical hotel that's affordable for families to stay in while their loved one is there. Something so simple like helping with travel to be with your loved one. Well, there's nothing scarier for an elder to be thinking about something that might be their last and not have their people around them. How does that help with their mental health and their ability to fight? Simple things, but they make a difference. Healing Lodge of the 7 Nations, 7 tribes. This was around substance abuse. So looking at those behavioral health issues in a cultural setting, and we've talked about that already, that if you're going to talk mind, body, spirit, and healing from chemical dependency, drug and alcohol addiction, that you have to reconnect people with culture. So these tribes got together. They looked at also those model funding where they're combining their resources, looking at lodging while they're there, inpatient treatment, and also those cultural traditions. Because they got accredited, it ended up being started because of suicides, youth suicides. If the pain's too much and the drugs and alcohol don't fix it, eventually what you're with is a rash of suicides. And so they were really worried about their young people dying. So this is how they went about it. So what does all this mean? What is the kind of overarching themes that we can look at from a US Indigenous perspective? Don't impose answers, that doesn't work. You provide opportunity and you make them as flexible as possible. And you listen to those communities and allow them to tell you what's most important to them and how to prioritize it. In one community, it might be that youth suicide and behavioral health. In another community, it might be nutrition. It might be community gardens and access to traditional foods and co-management of their traditional lands, right? Flexibility in funding. That whole big brother approach of we're going to give you the money and then tell you how to spend it, it just doesn't work. You need the flexibility. Tribes are doing some of these prevention programs for youth with health money. With health money. Their cultural programming and after-school programming. Why would that be a health program? Because without those access to positive identity and safe place, they're going to exhibit behaviors that are unhealthy for them, right? They're going to suffer with mental health issues. They're going to place themselves in situations where they're going to make bad decisions. They're going to be faced with using at a young age. This is about prevention and taking care of those future issues. Capital is the biggest issue we find in terms of building. Brick and mortar assets. Service delivery money comes better than it does. None of this works if it's in a facility that says you don't care, right? And the plaster's falling and it's ugly and it's not who your people are. So culturally relevant spaces matter in good repair that shows the value that you're putting on the services that are under the roof. Obviously, and this was spoken about earlier, it needs to be from the people that you're serving. This should be intuitive, right? But it's really not. And the reason it's not intuitive is because majority culture has always been served by majority culture, so it doesn't seem like anything special, right? But once you remove that and you see why wouldn't they want to be served by their own people as well, right? Multi-sector approaches, everybody at the table, break down those silos. Health is along a continuum of prevention to end of life care, right? And how does that happen in a good way so that our elders could go on their journey feeling like their community is in the good care of people behind them, and how can that be done in a cultural way? But it needs to be happening across our institutions. One of the biggest challenges to me during the Obama administration was to have the Department of Health and Human Services know that they should be talking to the Department of Education, that we can be doing good health care and good education, and some of those things should happen in the same place, right? So that kids have the option to have that ability to do it, even if something isn't available. And in fact, one of the tribes, the Montana tribes, is partnering with mainstream schools where there's high numbers of indigenous folks to do some healthcare services right in the schools. So multi-sector, think outside of the box of what we traditionally think is healthcare. The last thing is Aboriginal data sovereignty. A lot of us are challenged by a lot of people who like to study us, and that's really by a Western lens, right? And people will write indigenous communities into grants and not even talk to them about it. You know, it was a scandal in the US, you know, using our DNA, you know, without permission, saying it was for something else. If you're going to use Aboriginal data, it needs to be done in partnership with Aboriginal communities under their leadership, their interpretation, and their ownership, or just stay away, you're being predatory. And that concludes my remarks. In my language, miigwech, thank you. Thank you for your interest in the health and well-being of Indigenous communities. Thank you.